My name is Oleksii Barash. I'm currently IVF lab director at RSC in San Francisco Bay Area. I have PhD in embryology, essentially. I grew up in Ukraine and I moved to the United States 13, 14 years ago, and I joined RSC shortly after. So last 13 years, I'm with RSC here in the Bay Area. I would say the goal of PGT is to get healthy baby and to get it fast. There's many definitions how people define objectives of PGT, but I think if we're going to go to the core, it's just to get the healthy baby and get it fast. And this is why we actually do PGT for most of our patients, because we definitely see the positive impact. And I think with PGT, at least at our practice, we can achieve those two goals. We gain healthy babies and we get it much faster than we would do it without PGT. I would say the biggest one is complexity, because there's so many variables involved on lab side, on reference lab side. And I also think the technology is still far from being perfect. There's many ways how PGT can be improved, at least in my dreams. But as of today, I think so many factors can affect PGT outcomes. And I think this is the biggest limitation. I think it's not yet standardized to the level I would love it to see and be standardized. So I think it's still a lot of manual labor and a lot of decision-making on lab side and on the reference lab side. I think this is the biggest disadvantage of PGT. By its nature, it's a screening test. There's no doubts about it. But at the same time, because of the cost of this mistake is so huge, and unlike many others, screening tests, it's actually invasive. And so I think the lines were blurred. I think like legally, it's definitely a screening test. But I think, unfortunately, from the patient standpoint and from physician standpoint, even though we call it screening test, we still have these expectations as a diagnostic test, which means we want to have the final answer. And I think many patients, and actually some physicians, also have a hard time to deal with the complexity and with this ambiguity that, PGT is still a screening test. We will never able to, at least with the current level of technology, have diagnostic accuracy for PGT. In my opinion, we still have to rely on reference labs, and personally, I don't have enough level of expertise to question results. So if PGT reference lab says it's abnormal, I think it's abnormal, and I personally would never recommend this embryo for the transfer. I think this is a part of the game. I think regardless how hard we try, it's just limitation of technology. I think some embryos are misdiagnosed. There's possibly that some embryos we cannot define and evaluate the genetic material. And by we, I mean reference lab in PGT labs. So this is why it's still screening test. And this is why every PGT test has certain level of misdiagnosis. So I think patients just have to accept it. And we all have to be aware that, yes, some embryos that called abnormal maybe are actually normal, but we don't know. And we in the lab on the clinical side, we don't have any other information. So if it's called abnormal, I would follow the only source of information I have, and I'm not recommend using these embryos for future if we have results which says this embryo is abnormal. I think they should, because information has its properties. If you have this information, you're supposed to act on it. In the past, we didn't have this mosaic information, and embryos used to be black and white for us, but now there's 50 shades of gray with all the kinds of mosaic embryos. But I think it's all come down to the comfort level for the patients, physicians, and the labs also. And people in the lab and physicians have to define which embryos are actually available for the transfers based on their criteria and which one are actually not available. It comes down to the risk tolerance of particular patients. Some of them will be more risky and say, hey, I will transfer this embryo even though it's mosaic. And some patients will say, I don't want to take any risk at all, like zero. I don't want to have this embryo to be transferred. But at the end of the day, it's patient decisions. This is why I'm saying it's 50 shades of gray, and unfortunately, only patients and physicians can make the decisions. It's very personal, it's very individual, and it also depends on probably hundreds other variables of patient situation, how many cycles they can afford, what risk tolerance, what their financial situation, and so many. So unfortunately, it's not black and white anymore. This mosaic embryos introduces so many levels in between, and we have to deal with this technology in this way that it's not black and white anymore. There's several levels how we can look at this question. I think for the most part, the most important answer would be, what is live birth rate per transfer? I think ideally we should assess live birth rate per retrieval, but it's almost impossible because we almost never have opportunity to transfer all available embryos. So if I would have to look only on one factor, I would look at the live birth rate per transfer. But there's also many other factors like no-call rate, euploidy rate based on age, and overall performance in the lab, turnaround time, and things like this. But it's more technical. I think for the patient, the most important question is, how many embryos should I get based on my age, and how fast I can get baby if I have euploid embryo. It depends on experience level of people who are actually doing the biopsy. It depends on the techniques and protocols, and it also depends on the environment in a lab, like a physical environment, temperatures and pressure and humidity and so on and so forth. So I think we cannot improve embryo in a lab. So biopsy definitely has a risk, and it definitely can harm embryos. But at the same time, on some good labs, proper level of training and competency and experience can actually bring this risk to a very low level. And by low, I mean almost negligible. Negligible, but still present. It's a good question because I'm looking at this every year to see what's the difference between patients of the same age groups who do PGT and have embryo transfers without PGT. And even for the younger patients, I see the difference. And this difference is 5 or more %. And this patient gets older, and I mean by older, 35, 38, and so on, this difference gets even bigger. Because I see the difference even for the younger patients between PGT and non-PGTs, and this difference is favorable for PGT patients, I still would recommend doing PGT even for younger patients. If I would be a young patient, I personally would go through PGT despite the risk and extra cost, because I do believe it produces positive net value. I think it's only about conversations with genetic counselors and with physicians, because this technology is still very complex and still many inputs and many factors involved. So I think patients should understand what they're getting and what are the risks. I mean, hopefully in the future, it will be more straightforward and better technology. But as of today, yes, it does require some education and just understand the technology. It's unfortunately, there is no magic. There is still people doing tests, and the test itself has some limitations. So I think as long as everybody understand what the test is about and how to perform it the best possible way, I think it's possible to provide this information to the patients, and it's possible for the patients to have informed decision and compare benefits and risks and make proper decision about regarding to do PGT or not to do PGT. I personally believe we're going to see a lot of good things in the next couple of years. Usually with all breakthrough technologies, changes are being accumulated slowly, but then rapidly we get some progress. And we've seen it with fish, with RACGH, with NGS. I think what we're going to see soon, we're going to see with possibly we're going to be able to do PGT in a lab, something like a benchtop test, so we don't have to freeze embryos. I think we're going to be seeing colliding of AI kinetics and PGT genetic test itself. I mean, we already see cost of PGT goes down significantly. I think we're going to see much faster turnaround times. Hopefully, maybe non-invasive PGT is going to get improved, and we're going to see more concordance between invasive and non-invasive PGT. And I think we're going to see all these changes kind of get together and be available for the clinical practice pretty soon, like probably not 2025, maybe late 2026 or even 2027 for sure. Even now, I see some small sign that, it's getting the right direction. And right now there's so many PGT patients, so more and more time and talent being dedicated to these technologies. Hopefully we will see a lot of improvements in the next couple of years.